This discussion is going to focus on the gastrointestinal and hepatic biliary systems. Okay, so looking at the anatomy and physiology, so this is just some background information and some stuff relevant, particularly as it relates to physical activity. So gastric emptying accelerates with the onset of exercise. So when you kind of start exercise, the emptying of the gastrointestinal tract does start to pick up. However, it'll gradually start to decrease. So as the intensity of exercise starts to get higher. So as we give an example here, it'll gradually decrease at about 75% of aerobic capacity. So what that's basically saying is that as the exercise intensity starts to go up, gastric emptying is going to slow, and a lot of that's going to be because of the redirected blood flow going to the working muscles. So that's going to have an impact as far as what the individual will have kind of in their digestive system, what they recently ate, and that's what kind of makes a lot of the like pre-exercise meals, important as far as what's actually contained in them. Lower GI motility is going to increase with regular exercise. So, an individual who is active will have, good motility with their lower GI tract. However, during exercise, small intestine motility decreases. Again, another thing to keep in mind as far as the timing and the type of food that gets eaten prior to activity. Movement of the large bowel during exercise can cause cramping and diarrhea. So again, we look here at different ways. So this is kind of just an informal thing. It's not a homework assignment, but what would be some preventative things that could be done? And there's some things that you could think about that could possibly prevent some issues. So just think about, maybe write a couple things down in your notes. And so there are pretty simple things that could avoid issues as it relates to cramping and diarrhea, because those are going to be common things you're going to see in active individuals based upon the food they eat and how they kind of manage that. If we look here at the upper and lower GI tract, so the upper GI tract is going to consist of everything from the mouth going to the duodenum. So that the role of that part of the gastrointestinal tract is to take in and begin to digest food. Then the lower is basically going to be everything from the jejunum through the rectum, and the job there is to basically expel waste and do further absorption. So continuing on looking here, so now we're going to look at some other structures involving this region. So we're going to look at the liver, the gallbladder, and the exocrine pancreas. So the ampulla of Vater is going to be where all of the structures are basically going to go through this opening. So this is an important opening in this area, and all of these things are going to basically secrete digestive enzymes into the duodenum at this common location. So that's going to be where, from the standpoint of helping with digestion, where all of these structures are going to release their enzymes into. In looking at the liver, so you can see the liver here and how it's positioned. So the liver is basically, a lot of the roles of the liver. It's going to filter blood before it returns to the heart. It helps to metabolize fats and cholesterol. It's going to store carbohydrates, and it's going to form bile. The gallbladder is going to be where bile gets stored. And what's relevant about bile is bile contains both pigments and salts that kind of emulsify fats as part of the digestive process. And most of the bile salts are going to be taken through the GI and hepatic circulation, and the pigments from it basically get excreted in the stool, and that kind of what gives stool part of what gives stool its color. Then we move on to the pancreas, and the pancreas really has two functions. You have the endocrine pancreas, which is responsible for secreting hormones that regulate carbohydrate levels, and we'll talk more about that when we discuss the endocrine system. But from an exocrine standpoint, it basically releases enzymes to help digest carbohydrates, proteins, and fats. So we kind of see the digestive functions of all of these different organs within this part of the systems that we're discussing. Okay, so one of the probably more important things from a clinical evaluation standpoint is understanding the abdominal quadrants. So when we look at the abdominal quadrants, the abdomen's basically broken up into 4 portions, and based upon the signs and symptoms and the location of maybe the symptoms, maybe where they're having pain and the type of pain, can really start to tell you which organs or which part of the gastrointestinal hepatic biliary system could be causing the problems. So if we look at the upper right quadrant is going to contain the liver and the gallbladder. The upper left, the stomach, spleen, and the pancreas. The lower right, the appendix and the ascending colon. And then the lower left, the descending colon and the sigmoid colon. So here's kind of a picture of all of these structures and how they're present. And your book actually has another illustration kind of actually showing where the borders of the quadrants are. And you could kind of see here. So again, when you're palpating the abdomen, we'll talk about from an evaluation standpoint kind of how you should start that process. You could, one of the things you're obviously going to ask the patient besides, what type of pain are you having, when does your pain occur, you're going to ask them where do they notice their pain, and that could start to give you some further insight into, based upon understanding the abdominal quadrants, where their issues could possibly be coming from. So looking further at signs and symptoms, you have your nausea and vomiting. Now, again, look at the flow charts as they're kind of illustrated here. So on 8.1, you can see again a clinical decision-making flow chart as it relates to if someone does come complaining of nausea and vomiting. Nausea and vomiting is going to be caused by, again, it's indicative of some type of upper GI problem. And it's basically going to be caused by the nerve endings in the upper GI getting irritated either by chemical, mechanical means, or having autonomic stimulation through the vagus nerve. And hematemesis is going to be when blood appears in the vomit. So it's important to note if you do have blood in the vomit that you kind of are aware of where it's coming from. So in other words, a person with like nose or mouth trauma may inadvertently swallow and then vomit bright red blood. However, if blood is going to appear or collect or pool for some time in the stomach before being vomited, the vomitus typically has more of like a coffee ground appearance, so it tends to look a little different. So if it's bright red blood versus maybe like a darker blood, that's something that you could kind of note, and that could give you some insight again onto what the source of the bleeding may be. Upper GI bleeding could be coming from various sources. It could be coming from gastric ulcers, excessive use of NSAIDs, alcohol abuse, or any type of major systemic illness. Even sometimes from excessive exercise. You could possibly get from excessive exercise some upper GI bleeding due to some mild trauma occurring at that region. And then anytime you're noting abdominal pain in general, again, note the location, severity, and the quality of the pain. Again, there's another flow chart that you can review that kind of goes through some clinical decision making as far as how to handle the pain. Again, kind of note the pain, if it's cramping, if the pain's constant. Constant abdominal pain could be, due to irritation of the parietal peritoneum, or is it more of an intermittent cyclic type cramping, which could be due to like an acute inflammation or obstruction in an abdominal organ. Note if it's like an acute localized pain. That could again tell you if there's inflammation of the parietal peritoneum. So again, note all of those different things as far as like what, where their pain's coming from, how often they're noticing it, is it constant? Those could all be things that can clue you in as far as what might be the source of that pain. Looking further at signs and symptoms, you look at abdominal rigidity. So anytime you would have abdominal rigidity, that's going to require immediate medical attention, because that's going to be telling you that you're going to have a pretty severe issue going on in the abdominal region. And essentially when you would go to palpate the abdomen, again, at rest, you should be feeling a very, a soft abdomen. And in the case that, there's maybe an injury or internal bleeding or a severe disease state of an organ, the abdominal wall is going to go into spasm, and that would tell you that there's a more immediate problem that would need immediate medical attention. And usually this is going to occur in a particular quadrant. Loss of appetite or loss of body weight, and this could be indicative of a lot of different things. Again, this is why you'd have to kind of connect your various signs and symptoms through your clinical evaluation. Again, it can indicate upper GI problems. If you have significant loss of body weight, again, various causes to that: poor nutritional absorption, recurrent vomiting, diarrhea, increased metabolic demand from chronic disease. An infection and cancer could cause this as well. And again, any night pain, which again would be, you'd want to make sure you would rule out some serious conditions, particularly cancer, because again, night pain shouldn't be something that should be obviously occurring normally. And if someone's having pain that's waking them up at night while they're at a state of rest, that would be cause for concern. Okay, prandial and postprandial symptoms. So prandial symptoms occur while eating, postprandial occur after. So if pain does occur after eating, kind of note how much time has passed since after eating to kind of determine maybe where the pain could be coming from. So stomach-associated pain usually begins a little bit sooner after eating, obviously, because food's going to go through the stomach first. So about an hour after eating, as the food kind of passes into the duodenum, and then duodenal pain usually occurs about 2 hours or more after a meal as food starts to pass through further into the gastrointestinal tract. So that would be important to note. Food also tends, so kind of before we get into bowel habits and stool quality, food also tends to irritate a gastric ulcer, but tends to relieve duodenal ulcers. And again, kind of note the type of food that individuals are eating. Things obviously like alcohol and caffeine can irritate certain issues as well. Bowel habits and stool quality. So obviously, you two ends of the spectrum here. You have increased bowel motility with diarrhea. Again, there's an algorithm that you could look at to kind of determine the cause and kind of how to treat it, versus constipation, which is decreased bowel motility. So again, obviously with diarrhea, you want to make sure to maintain hydration and electrolyte levels. You could possibly use different medications to reduce bowel output, things like your Pepto-Bismol and Imodium. The BRAT diet, which is a bland diet, the banana rice applesauce toast diet, can also help to relieve a lot of things associated with diarrhea. As far as constipation, there's again various causes of that. Stress, inactivity, various GI diseases could cause that. So again, it's a symptom of something. It's just a matter of finding out what the direct cause is. And then any type of rectal bleeding. So hematochezia is a bright red blood in the stool. Again, this could be caused by something not necessarily directly related with like the intestines and what have you. This could come from like hemorrhoids or even anal fissures. However, there are things obviously with the intestinal tract and things like that could cause that. IBS could cause some hematochezia, cancer, parasitic infections could also do that. And then melena is representative of upper GI bleeding. So that's when you have that dark, as they call it, tarry stool. So if there is blood in the stool, that would be something to note. Is it kind of that darker tarry type color, or is it more of like a bright red blood? So jaundice is something to make note of. So jaundice is a yellow discoloration of the skin, eyes, and mucous membranes. And what this is indicative of is excessive bilirubin in the blood. So this represents a pathology of either the liver, the gallbladder, the exocrine pancreas, or that common bile duct. And the other thing you will tend to see with this as well is that the urine will start to darken and the stool will actually lighten. So bilirubin gives stool its dark color. However, again, when there is excess bilirubin in the blood, more of that's going to end up getting excreted in the urine. So it's actually going to cause the urine to darken and the stool to kind of lighten up more. We start to look at pain patterns. So again, we look at upper GI, similar to the heart. So it's of course important to note, to make sure that you're not having cardiac symptoms. So again, part of your assessment is going to be to kind of differentiate that, obviously. But so a lot of the upper GI pain tract, very similar to the heart. So it's kind of that substernal, and you have your epigastric pain as well. So epigastric usually, if they have epigastric pain, it's usually representative of something going on in the stomach. If the back or shoulder could also start to get some pain, if the diaphragm, the diaphragmatic pleura becomes irritated, and that could also come from the stomach as well. If we look at the lower GI, you could get more of that like diffuse middle lower abdominal pain. Obviously, one of the very important things to point out is what's called McBurney's point, and that's usually where you'll get pain that gets referred from the appendix. So the appendix is in that lower right quadrant, and that's where you would have McBurney's point. So about a half to a third of the distance, if you go from the anterior superior iliac spine inward, that's where McBurney's point would be. So, obviously an extreme amount of pain and tenderness there would indicate that, possibly an appendicitis would have to be a part of the differential diagnosis. So here we also have, I'll just pull all these up. You could also see some of the other areas where pain patterns will be referred to. So you can take a look at this illustration. I'll talk about some of these. So when we look at the liver, obviously look at the right upper quadrant. Pain could also go into the right shoulder, the thoracic and cervical spine. Through the T8 dermatome, it could radiate to the right scapula. You could also see where the gallbladder would also refer pain from, and the pancreas. The pancreas usually is going to cause some epigastric pain that'll refer into the middle or low back. The left shoulder could also have pain with the diaphragm as well, or with the pancreas as well. That's again if the diaphragm becomes irritated. And also I noted up here with the spleen, even though not a digestive organ per se, but the spleen's obviously in the abdomen, so we have to be thinking about that when we're, obviously particularly for like traumas, showing you where the spleen pain referral would be as well. And we refer to that's referred to as Kerr's sign, KEHR' sign, and that's where you would have some pain with the spleen. So for inspection and examination, so again, for your history, again, think of what questions just based off of, so you kind of have an array of signs and symptoms, so be thinking of the questions you would want to ask, when they're having pain. Is it associated with eating? Is it associated do they have pain while they eat, after they eat? If they have pain after they eat, when does it start? That kind of starts to clue you in as to, what part of the gastrointestinal tract could become a problem. For inspection, so again, if you're just examining the abdomen, look for any type of protrusions. So ascites, any distension due to obstruction or excessive gas. Be thinking of, once you get into your, palpation part of your exam, you'll start to feel if there are any masses present. Again, also as a part of inspection, look for any jaundice or any type of muscle spasm. Hepatomegaly and splenomegaly, enlargement of the liver or spleen. For examination, again, auscultation, so you're going to be listening for bowel sounds, so you'll be putting them in a hook-lying position during examination, and you'll be listening in each one of the individual quadrants. And, you might want to listen for, up to 1 to 3 minutes for your bowel sounds. And again, when you're listening for bowel sounds, you're just going to be hearing like I equate it almost sounds like a little bit of like a tinkling kind of noise. And you should hear about 5 to 35 sounds per minute. If you're not hearing any sounds, you can be concerned about a bowel obstruction. Obviously, if they have like increased motility because of diarrhea or something that you would hear more bowel sounds. You can do your percussion again, and you could do that particularly for the spleen and liver, because that could also help you in determining the size of the spleen and liver if you were worried about enlargement. Again, and you could kind of still do percussion throughout the rest of the abdomen. Again, you're looking for changes in resonance. So obviously a lot of your abdominal organs are hollow. So again, determining whether you have to first know, are you listening to a hollow or a solid organ? If you're listening to a more solid organ, you should be hearing more of like a dull thud. If you're listening to a hollow organ, you should hear a more resonant sound. Now, if you were to hear, for instance, like a dull thud in an area that should be hollow, that could tell you maybe there's internal bleeding or fluid in there, and that would require, obviously, a check for that. You want to note heart rate, blood pressure, any radiating pain. Again, that would be a part of any general examination if you're looking at something more systemic. Ask them if they're having pain in the back. Musculoskeletal versus abdominal organ trauma. So that's something interesting to note. So, and one of the things you'd be looking at if you're looking for abdominal organ trauma or pathology, rebound tenderness is going to be something you would find typically. So if you're palpating the abdomen and it's tender, find out if it hurts more when you kind of release the tension. So if you push into the abdomen and let go, and the pain increases upon letting go, that's your rebound tenderness. So that tells you that's more likely an abdominal organ issue. The parietal pleura could be inflamed, what have you. If it's just a musculoskeletal injury, you'll likely just have, when you're not touching it, the pain should subside slightly. So that would be something that you would want to note, and that could help you differentiate between whether you're looking at an abdominal organ pathology or a musculoskeletal injury. Okay, so another important check we'd want to be doing is checking for dehydration. And clinically, there's various things you can do to check for dehydration, but this is one that you can utilize as well, is to check heart rate and blood pressure and note the changes that occur from supine to standing. Now, under normal conditions, the heart rate and blood pressure is going to change slightly when you go from supine to standing. However, it should increase by the heart rate should increase by less than 20 beats per minute, and your blood pressure number should decrease by less than 20. So if that's not the case, if your heart rate increases by 20 or more and your blood pressure numbers decrease more than 20, what that tells you is that the individual is dehydrated. So that would, again, that would kind of tell you what you'd have to do as far as your treatment's concerned. And then there's something called JARS test, which just could tell you is if you have a peritonitis. So it could tell you if the abdomen's inflamed. So basically what you do for this is you go up on your toes, you have the patient go up on their toes and just kind of drop on their heels. If that causes pain in their abdomen, because basically what it's going to do is, it's called JARS test. It creates like a jarring effect in the abdomen, and that would tell you if they have that, peritonitis, or the peritoneum's inflamed. And again, that would require further evaluation. Some other things you'd want to look at, and again, a bowel obstruction, and again, you'd have to find out what the cause of the bowel obstruction would be, but these are all different things you would be looking at as far as if an individual had a bowel obstruction. Again, vomiting, progressive cramping pain, a distended abdomen, foul breath odor, an inability to pass gas, diminished bowel sounds, tympanites, or systemic, any other type of systemic issues could all be indicative of a bowel obstruction and would warrant further referral.